Welcome back. This is episode 40 of the MedEdit podcast, your go-to source for evidence-based medical education.
And the only podcast where two board-certified physicians interview specialists on the topics that you guys care about.
Today's topic is a big one, endometriosis. Whether you've been diagnosed, suspect you may have it, or you're just curious about how it can impact fertility and quality of life, this episode is for you. And on a personal note, this is something that I dealt with growing up and told that it was all in your head, went through many, many years of trying to figure out what was happening. And so this is a very important episode to a lot of women in the world. And we are joined by a very special guest, board-certified OBGYN Dr. Lawren Honken, who many of you may already know from Instagram as the @yourfriend, the OBGYN. She's here to break down the facts, debunk myths, and help us understand what actually works when managing endo.
And I hope you're all ready to get your mind blown by some statistics today. One of those is that according to CDC, 1 in 10 women of reproductive age in the U.S. have endometriosis, which I feel like is probably low, but CDC usually is low based on what we see in clinical practice. But yet, even though it's relatively common, it can take years to get a proper diagnosis.
It sure does. If you know someone who's been told that period pain is just normal, or if you've ever left a doctor's office feeling dismissed, this episode will feel like a big, validating hug and also give you some real answers.
So let's get started. We are your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray. Welcome to the MedEdit podcast. Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
Dr. Honken, we are so glad to have you here today.
I'm so happy to be here. Thanks for having me.
Before we dive in, let's give our listeners a little background. So Dr. Lawren Honken is a board-certified OBGYN known for her approachable and empowering style of patient education. She completed her medical degree at the University of South Carolina School of Medicine in Columbia and then completed residency in obstetrics and gynecology at the Augusta University Medical Center in Georgia. She's currently getting her graduate certificate in integrative medicine with George Washington University. She practices full-scope obstetrics and gynecology in South Carolina. She's also that friendly voice behind Your Friend, the OBGYN, a popular social media account where she breaks down complex topics in reproductive health and advocates for patients navigating conditions like endometriosis. She is passionate about helping women feel seen, heard, and informed, and we are thrilled to have her with us today.
I'm thrilled to be here.
Yes. Well, let's go ahead and get started with the basics. What is endometriosis?
Well, first of all, this is a lot to unpack, and obviously we don't have enough information about it, so we don't really have a lot of research about it. But in general, endometriosis is a whole body chronic disease process that basically causes endometrial-like tissue to grow in places in the body that are outside of the uterus that you normally wouldn't have endometrial-like tissue. So endometrial tissue basically is the hormonally responsive lining of your uterus that grows and sheds during your menstrual cycle. And like this tissue, endometriosis is hormonally responsive as well, and it can progress and regress, and through all of that contribute to many symptoms, the effects of it, and complications. And these kind of endometriosis or endometrial-like cells are responsive once they implant to estrogen stimulation, like from the ovaries and then even from the cells themselves. So leads to a lot of inflammation, scarring, and adhesions.
So I guess that really, when we talk about this, like what causes endometriosis, and then why is it so difficult to diagnose? Most patients who come in and they hear about this diagnosis, maybe online or research themselves, they say, well, why can't you just order an ultrasound and see it? Why can't you order an MRI and see it? So why can't we do some of these simple tests? Why is there not a blood test?
I know, that would be amazing. I mean, and I think the blood test is kind of the wave of the future for endo. I really hope. I mean, that would be great if we had a more non-invasive diagnostic test, because truly the only way to diagnose endometriosis is through surgery. So that is the way that you're going to get a definitive diagnosis. And as far as what causes endometriosis, I mean, like I said, we don't have enough research. We really don't know. There are a lot of theories, but none of them are definitive. And endo is so multifactorial that there are just so many factors at play into its origin and causes for many patients in general. So one of the theories that we learn a lot usually in OBGYN residency, but also I remember learning this in medical school, is the retrograde menstruation. So basically how your, like the endometrial lining, instead of shedding and coming out of your cervix and out of the vagina, is going backwards through the tubes and into the abdominal or peritoneal cavity. But about 90% of patients or women have this retrograde menstruation, but not all of them obviously are going to have endometriosis. And also it doesn't really explain how there are endometriosis implants that have been found, for instance, like in the chest cavity, in places where retrograde menstruation wouldn't go. Also, women that are, have already had a hysterectomy can have endometriosis. Women after menopause can have endometriosis. So it doesn't really explain everything. And there are just a lot of things at play, and including like immune dysregulation, cellular proliferation and cellular signaling, some somatic mutations. I mean, we know there's a hereditary component, and just that these implants can kind of like proliferate on themselves. They get new vasculature or blood supply. They get and make new kind of nerves and kind of stimulate themselves in that way.
I think that's wildly fascinating that with all the technology we have, with all the research we do, especially, with all the research that's focused on things like IVF, because we do have a lot of, in the infertility world, because that's all kind of like still up and coming and stuff. We still can't figure out what causes this extremely painful and decently common diagnosis. And like we said before, it's probably wildly underdiagnosed, because the only way to figure it out is if you actually cut somebody open. And I'm pretty sure most OB-GYNs are kind of waiting till the last resort to try to cut someone open for that diagnosis. But I mean, it's just so crazy.
Yeah. And I would just say, catch that with like, we shouldn't be waiting. You know what I mean? Like, as long as, the patient is aware, and that is on the patient too, because a lot of like, it's a big deal. It may not be a big deal to a surgeon to cut someone open, because that's our job. We do that all the time. It's no big deal. But when you're undergoing surgery, you have to undergo anesthesia. When you're talking to patients about like, this is the only way to diagnose it. I mean, some patients are very hesitant. It's a big decision to make, to undergo a surgical procedure, but it also shouldn't be a last resort. We shouldn't have these hoops that we have patients jump through where like, oh, did you try birth control pills? Did you do this? Did you do this? Then, okay, now I'll do your surgery. And kind of if you're at that place as a patient or as a gynecologist, you feel like you're telling patients that, just send them to a specialist.
Yeah, exactly.
Yeah, no, for sure. I feel bad sometimes, because as part of that workup, a lot of times I get asked to do colonoscopies on this patient. There's been literally times where like, well, you're going to see it during this procedure, right? And I'm like, God, I hope not. Like, if I can I'm in the wrong place. Like, don't want to see any endometriosis on this test. But I mean, it's true. Like you said, it's kind of that same thing. It's like they feel like they have to have that to get to the point of having surgery. And I feel bad again, because most of the time I'm going to see is absolutely nothing. Just kind of check box that we did it and it wasn't something inside their colon. And, I see that people being really desperate for answers.
Yeah. And I mean, I think that just goes to show, and I mean, there are even, there are patients that I've seen that have not had surgery yet, that I've seen several gynecologists, and I'm not an endometriosis excision specialist. I'm a general gynecologist, but I've seen several patients that I suspect have endometriosis, and just telling them, like, I suspect you definitely have endometriosis. Until proven otherwise, I would just move forward with the understanding that you have this and you're going to deal with this for your life. And just, of course, that's kind of like the bad news, right? That is a chronic illness. But I think like the relief that I get to see in some patients' face to just have somebody that's just validating, that's listening, and that's saying that, like, yeah, I agree. I mean, I think women that have chronic pelvic pain and have a delay in diagnosis, they have endometriosis or any kind of on that spectrum, these are some of the most well-researched, the most, like, the smartest women. I mean, because they've had to be, right? They've had to advocate for themselves. They've seen doctor after doctor. They've read, I mean, they're, reading all the time. So, I mean, just the fact that, to be able to give someone the validation of it, I think is a big relief to a lot of patients.
You're describing my entire teenage years and my early 20s, and that I'll never forget. I've had multiple surgeries until we finally got to that surgery, and I'll never ever forget that I woke up still in the OR. That's how vivid this response was. I was still in the OR with the surgeon. She was a specialist in this. And I woke up and I sat up straight in the bed, still in the OR, and it terrified everyone in the room. Looked directly at my surgeon and said, "Did you find endometriosis?" In the most she repeats the story all the time. And she said, "Yes, we did." And then I said, "Thank goodness." And then I fell back to sleep. And it was the most dramatic thing. And she tells this to her students, her residents, and her fellows, this story as a good example of whatever adrenaline response had right after, she's they barely extubated you. It was ridiculous. And I just woke up immediately and just asked, because I was so much, I think, going into this, so much pressure on, is someone going to find the answer finally of why I've had all this pain for so many years? And I think she and herself too felt relieved that, you can, okay, we have a diagnosis. Doesn't mean you fix the problem necessarily, but we have a final diagnosis. But yeah, tell us more about some of those typical symptoms, because obviously they vary wildly between individuals.
Yeah, for sure. I mean, so there are so many symptoms, but the classic symptoms of endometriosis are dysmenorrhea. So just very painful periods. And certainly you can have pain with your period without having endometriosis, but pain with your period, kind of like the normal cramping feeling, is usually going to resolve if you take NSAIDs or anti-inflammatory medication. Pain with endometriosis is more going to affect your life, your ability to do your normal day-to-day things. It's going to affect your productivity, your social life, your intimate relationships, your mental health, all of these things. And so those are the women that we worry about endometriosis in, or that's kind of a red flag to me. Also, dyspareunia, so pain with intimacy or intercourse. A lot of women will describe this deep pain or hitting pain when penetration is happening. Pain with bowel movements. You can even see blood in your bowel movements. Pain with your bladder filling, or pain with emptying your bladder. You can see blood in your urine as well. And then infertility is also a symptom of endometriosis. I mean, up to 40% of women that have infertility have endometriosis. And then there are some super vague symptoms that these play into kind of making it more difficult to diagnose, because there are a lot of things that can cause abdominal pain, bloating, potentially abnormal uterine bleeding or postcoital bleeding after sex, low back pain, fatigue. And then you can get even, more rare, but symptoms where diaphragmatic implants or endometriosis in the thoracic cavity, and women can have shortness of breath, pain at their bra line. They can even have hemoptysis, so coughing up blood, and pain with deep inspiration, chest pain, shoulder pain. There are even cases of pneumothorax that women have had endometriosis. So pretty widespread set of symptoms.
Yeah, that's crazy.
Mm-hmm. Yeah, and you mentioned the infertility already, but why is that? Why is it such a common cause of infertility for women?
I mean, endometriosis affects fertility in so many ways. So as I was describing before, it can cause inflammation, scar tissue, and in that way can cause anatomical changes. So it can cause scar tissue, adhesions in the pelvis, which can obstruct the fallopian tubes, so not allowing kind of the egg to meet the sperm in the fallopian tube. They can also affect ovulation in that way, sperm transport or infertility, or implantation of an embryo in the uterus. You also can get endometriomas, which are these ovarian cysts that are full of blood, and these can affect ovarian function. They can impact ovulation. The inflammation and scarring can kind of harm even the developing embryo, but also the inflammatory effects of endometriosis can affect the lining or the endometrium and cause an embryo not to be able to implant well. And also through the immune system effects endometriosis certainly can alter the immune system response and lead to potentially like an early miscarriage or even a difficulty of a developing embryo to kind of take hold and continue to normal pregnancy.
No wonder it's so hard.
Oh yeah,
Endometriosis affects everything. Is what it sounds like.
It does, and that was when I met with one of our specialists. Actually, I had we've talked about this before on the podcast. I've had to go do my REI stuff up in a different state, and when I went up to CCRM in Denver to do stuff, I met with one of like the founders of like IVF. He's like an amazing surgeon and specialist out there, and he was talking about endometriosis, and he said that they have done research where they took pelvic fluid, just like the fluid from the cavity of the, inside, nothing related to the actual lining of the endometrium, but they just took the pelvic fluid of somebody who has endometriosis and they put it in a petri dish, basically with some eggs, and they watched it degrade the eggs. So just the fluid that's in the normal cavity, the inflammatory properties that have happened because of its exposure to the endometriosis, being in that cavity, not actually the actual cells itself, but just the exposure. And I guess the inflammatory properties that you can have in that fluid just degraded egg quality immediately. And so he was talking about for endometriosis, unfortunately, things like IUI or things sometimes like Clomid and letrozole and things to try to help you get pregnant and ovulate correctly usually don't help that well. And that's why they jump all the way to the IVF sometimes, and they have to do the embryos. And if you're like me, then you do all the embryos and some of them don't take. And then when they don't take, it's because of all this inflammatory response from endometriosis. So it's just so interesting that even these, world-renowned specialists in the area of endometriosis are still saying, we don't know how this works. We just know it's incredibly powerful.
Yeah, I can't imagine. I mean, I can't imagine all the stuff he's seen.
Yeah, I'm sure. His stories. He's a little older. I don't think he listens to the podcast, but he definitely. Shout out to Dr. Schoolcraft at CCRM. He definitely is amazing and brilliant. He like writes the textbooks on all the IVF world. But it is very interesting because what they've seen with endometriosis, I think some of the things they do in their research, there's probably changing the way that we approach things like this. So for OB-GYNs like you who are like, hey, let's just get informed consent and let's go to surgery or have those conversations. But are there surgical or non-surgical options? What actually helps? What does the studies or recommendations show?
Yeah. So, I mean, first, and I think we already said this a little bit, I mean, we have to be clear that there's no cure for endometriosis, right? So, I mean, if someone is kind of telling you like, oh, this is going to take away your endometriosis or cure you, that's just not true and it's not validated. And then pretty much any non-surgical option, which is going to be a medical option essentially, is going to be palliative. So it just is going to potentially and hopefully treat and help you manage the symptoms of endometriosis, like the pain-related symptoms, but there's no evidence that it does suppress progression or like the growth of lesions of the endometriosis. So, I mean, certainly there are medications that you can take and use, like hormonal suppression, so birth control pills, but those are more likely to kind of help the symptoms as far as like the dysmenorrhea or the pain with your periods. You can use birth control pills, obviously, to skip your periods or to make your periods lighter. And so it may help in that way, like an IUD potentially. It could help by making your period go away. So it can help in that way. Anti-inflammatory meds like NSAIDs, pain medications, those are really only going to treat, the pain or the active inflammation potentially that's going on. And then the other medicines that are like the GnRH agonists and antagonists, there's kind of a time limit on those. So, potentially you could use those, but you can't really use them for a long period of time just because of the side effects. So truly the gold standard for treatment for endometriosis is excision. And that's surgical treatment where excision, I mean over ablation. So cutting out the endometriosis lesions to get to normal tissue is the standard of care for endometriosis. The reason is because ablation or fulguration is really just treating superficial lesions. So, you're burning the tissue, but you really don't see what's under that. So there could be, this nodule that's under there that, you're just going to continue to have symptoms afterwards if that's not taken out. So the other thing that makes it difficult is that, you need an experienced surgeon, someone who operates and takes out endometriosis frequently, because endometriosis lesions can be very sneaky and very difficult to see and diagnose. So they're actually, I love this, but Dr. Mallory Stuparich, she is an endometriosis excision surgeon, and she actually told me that in experienced hands, so an endometriosis excision surgeon that does it all the time, they're going to get endometriosis implants right 80% of the time. So not even 100%, somebody who does it all the time. In inexperienced hands, or someone who doesn't really do a lot of endometriosis excision surgeon, they're only getting it right 40% of the time. So your best chance to have a complete excision, like a complete resection of your endometriosis, is to go to somebody that's experienced.
Wow.
That's really interesting. That's a really good approach too.
Yeah. And I'm glad that you mentioned about the kind of wrong information, because I do feel like this topic specifically is targeted a lot with social media and gaslighting as well, as far as for trying to sell something that's not validated. It kind of goes along with that whole whole body inflammation that we can cure.
Yes.
It just seems to be one that I see listed a lot. It's like, we can get rid of this,
Just buy this supplement and we'll turn down all the inflammation, including endometriosis. Man, and you know what? I will tell you, when you are in so much pain all the time, like so much pain,
easy target.
I would pay anything. Like, social media wasn't really that big back when all this started, like a decade ago for me. Otherwise, I probably would have been one of those ones just like buying whatever you could. You don't know any better, and you just want relief, right? And we always talk about this. It's my catchphrase, is that predatory medicine. These people are, propagating predatory medicine where it's something that does not actually help. It's misinformation. At best, it just doesn't help. At worst, it actually could make things worse or delay a true diagnosis and resolution. And they are doing it because you're handing them cash for it. Or making
No,
them
absolutely. No, absolutely. And that's why what you guys are doing is so amazing, because this is the only way to fight against that, is to just spread evidence through experts or people who actually take care of patients, and to do that so that people can learn. But huge red flag when people are selling something special and telling you that it's going to cure all your problems.
Well, yeah. And on that note, are there some diet supplements and alternative therapies that you do recommend, so people don't get bamboozled? We see so many recommendations, but we want to hear, what are yours?
Yeah, no, that's a good question. So, in general, I would just recommend overall, a whole food diet, trying to avoid things that are ultra processed, but an anti-inflammatory diet. So really like whole foods, minimally processed. Make sure you're hitting your fiber intake goal, lots of omega-3s and antioxidants. They did show a possible, Dr. Stuparich told me this too, possible, because that was my question to her, possible association, like a lower incidence of the diagnosis of endo in patients who were taking omega-3s, vitamin D, vitamin C, vitamin E, and actually seaweed. So it doesn't necessarily mean you're going to run and take all these supplements and your endo is going to go away or you won't get endo. Right. It just showed a lower incidence of diagnosis with these supplements. And so on the flip side, more or a higher red meat there was an increased incidence of endometriosis, which is interesting. And then there are some I know it is, and anti-inflammatory supplements that have shown decreased intensity of endo symptoms. And those are other, the anti-inflammatories that I already mentioned, like vitamin E, C, selenium, zinc. There's, turmeric, CoQ10, probiotics potentially could improve immunity and immune support. NAD, that's another one. But yeah, those are kind of the ones that I have seen. And, I think, like you said, as long as you're not risking delay in diagnosis and you want to try these, the risk of harm overall is low. So it's like, just try it. If it makes your symptoms better, great. I mean, I think everyone is so different. There's not going to be a one size fits all. And, if you can improve your lifestyle or your diet and make your symptoms better, then that's awesome.
Right.
Yeah, I think we always think that. We're just like, just remember, maybe talk to your doctor too about what you're doing, because more is not better.
Yes.
You come in and I'm like, hey, that
Yes.
insane amount of vitamin D you're on is going to cause a problem. Like, those vitamins we talk about, like the A,
Yes.
D, E, and K, like there could be problems there. So yeah, or we talked to another specialist, a rheumatologic specialist the other day, and she was talking about the levels of what you need in like the turmeric for the anti-inflammatory property are so high that, you might want to actually have that conversation to understand, are you going to take this 4 times a day? Because otherwise it just might be you wasting your money. So, have those conversations. And on us as providers, we need to be good about being open to those conversations too. And saying, okay, the research isn't all the way there on this, but that doesn't mean that we can't develop a plan together. Right.
Yeah.
Yeah.
Right. No. And then there are also alternative therapies that aren't necessarily, supplements, but I'm a huge advocate for pelvic floor physical therapy.
Yes.
I think everybody that has a pelvic floor should do pelvic floor physical therapy, which is like every human being. And then, just reducing stress in general, but people can do like acupuncture, dry needling. A lot of pelvic floor physical therapists do dry needling, which is more about where the tense muscle is, not necessarily along the energy lines like the acupuncture. But yeah,
I've tried all those things too. We could like have a whole other episode.
Yeah.
Yeah. Big shout out to pelvic floor. I think they're amazing. But speaking
Let's
of
do
myths,
it.
yeah, you should. We'll bring you back for the pelvic floor talk, because we do want to bring a pelvic floor therapist on too. So speaking of myths,
you
let's play our
should.
favorite game. We're going to play Miss or Fact. So you're in it with us. Okay.
Alrighty. So it's a game where we find social media trending topics and break it down into what is fact and what is myth or misinformation. Okay. Are you ready, Dr. Honken?
I'm ready.
Okay. Alrighty. So myth number 1, pregnancy will cure your endometriosis. Fact or myth?
Big miss on this one. Yeah. No,
Can you
no
tell us
curing
like
it.
why? Yeah.
Yeah. So basically, pregnancy, the levels of progesterone, it's thought, in pregnancy causes potentially endometriosis symptoms to get better. But the reason that it's a miss is because nothing's going to cure endometriosis. Number 1, fact. But number 2 is that your symptoms, once the pregnancy is done, are going to come right back. Also, pregnancy is not a neutral health event. So we don't want to be telling everybody with endo, like, you should just get pregnant. This will help you. And women with endometriosis, they can have like more complications or potentially more pain related stuff come up in pregnancy as well. So I'd say miss.
Great point. So number 2, you can't have endometriosis if you have regular periods. Fact or miss?
This is a miss too. Yeah, so you definitely can have endometriosis with regular periods. Not everyone is going to have abnormal bleeding if they have endometriosis.
Alrighty. And number 3, endometriosis will always show up on imaging. Fact or miss?
Miss for sure. Now, I will say it can show up on imaging, but definitely not always. So there are some really, like the endo specialists can do specific ultrasound techniques, and also they just have more practice, right, looking at endo on imaging. So they can see it, but yeah, usually it's not going to show up on imaging.
So number 4, you should just go on birth control and deal with it. Fact or miss?
Big, I feel, is this something you were told? I feel like
All
this
the
is coming
time.
from.
Yes. They're like, just get over it.
Yeah.
Like, this is just normal. We actually remember this started when I was with
Yeah.
a pediatrician, and thank goodness my mom, shout out to her. She was like, I think we're going to move you to a different doctor, because my pediatrician is just like, at 16, he's just like, you just have to get over it. You just can't handle your periods. So I'm like, I don't think that's what's happening. I think something is actively like wrong, like right now.
Yeah, coming from someone who's never had a period.
Yeah,
No,
right.
big miss. Yeah.
Yes.
Yeah, no. I mean, I certainly wouldn't tell anyone to deal with it. And if you're at the point where you're like having to deal with it, obviously like the risks of just continuing on with your life, taking birth control, which is palliative at best, you're might help your symptoms, but your disease is probably going to progress. Why, no,
Right.
don't do that.
I love it.
Awesome. Well, this is exactly why we do this podcast. We want to sort through all the noise with experts like you so our listeners get correct information. So thank you so much for joining us. And everyone, please go follow Dr. Honken at Your Friend the OB-GYN on social media. She has a lot of great information, very energetic Instagram reels, which I've been watching. So absolutely love it. And thank you again so much for joining us.
Yeah, thank you guys so much for having me.
That's a wrap on episode 40. If you're a listener claiming CME credit, please check the show notes for all those instructions.
And everyone, thanks for tuning in. Please don't forget to subscribe, like us on Instagram and TikTok, and let us know what other topics you'd like us to cover. We'll see you next time on the MedEdit podcast.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.